Hi, everyone. I am Catherine Ayers-Wickenhauser, Director of Communications for Direct Trust, and I am so excited to have Jenn Searls with me today from Connie HIE. Jenn is one of our most recent interoperability heroes, and I am so excited to hear about her story and more about Connie. So, welcome, Jenn. Would you introduce yourself and introduce Connie to us, please?
Yes, absolutely. Thank you. And thank you for having me here. And thank you for sort of recognizing Connie and our organization as interoperability heroes. I think it's more than just me, it's all of the team that helps support me. So I am a longtime healthcare IT professional here in the state of Connecticut and in Pittsburgh, where I graduated and started work right after school. I have been in the state for probably 15 or 20 years, working in mostly on the provider side in health IT and implementing electronic medical records. And so maybe this can lead a little bit into Connie and sort of how I got involved in Connie, because I think my story probably resonates with a lot of people. The person who was in charge of implementing an electronic medical record for a primary care group practice in the state of Connecticut, ended up needing data from about 17 different hospitals at the time, because the practice that I was a part of was the largest primary care group practice in the state. And as we implemented an electronic medical record, we of course wanted information on our patients as they were discharged from hospital systems. And at the time, that was 17 different hospital systems in the state that I had to go sort of knock on their doors and say, please, could I get information on my patients as they're discharged from your hospital or as they're admitted to your hospital? And didn't, to be honest, didn't make a whole lot of headway for a number of reasons, not the least of which is most of the health systems in the state at the time were really working through Epic installations, or we were all trying to get to meaningful use and figure out how to do that. And so it was a really hard, long slog. And I was really frustrated by that. After I left there, I went to an accountable care organization or a clinically integrated network where we had the responsibility for total cost of care for about 150,000 covered lives. And similarly was frustrated in that though our network was all affiliated with one health system, we had somewhere in the neighborhood of 40 to 50 different electronic medical records in our group. And we certainly wanted to give all providers in our practice the ability and the autonomy to select the electronic medical record that made the most sense for them. But as you can imagine, when I had to try to figure out how I marry clinical data with claims data, and I have 60 plus EMRs, it's a really challenging place to be in. And so we were able to get data from the hospital system, but not necessarily all of our practices as we were going. So that sort of led me to Connie. And I think is also the impetus for the state to develop Connie as a health information exchange for the state of Connecticut, sort of the official statewide HIE for Connecticut. So I think I got all your questions there.
Sure, yes. And it's so interesting to me, Jenn, because I think you touched on something that resonates with me, and that is kind of healthcare and health IT specifically. While it might be niche, it's still multifaceted. And thinking
Yeah.
about how many of us have that background from electronic health record implementation and training. That's my background too, before I got into compliance and then interoperability, and just thinking about how many of us encountered those challenges and saw them firsthand. And that's really driven us to now be part of the solution, right, with interoperability. So I know that Connie is a relatively new HIE. So maybe could you talk a little bit more about that and the evolution of Connie and how it came to be?
Yeah, so the state of Connecticut has had a number of runs at starting an HIE. And this, I think, not just because I'm running it, but because I think that we really are going to make it this time for a number of reasons. I think that we really have a great shot at getting this version off the ground this time. But yeah, so we had enabling legislation in 2017 that sort of enabled the setup of Connie as an HIE or Health Information Alliance. And in 2019, we actually incorporated Connie, or our legal name is the Health Information Alliance. In 2020, I came on board after the board had been set up and so the independent board that we have was set up, and a number of policies and contracts were set up for the organization. And so, like I said, I came on at the end of 2020. And then at the beginning of 2021, we were deemed operational. And sort of the significance for that in the state of Connecticut is that once we are operational, then a mandate starts that all hospitals and labs have to get connected to Connie within a year, and then all other healthcare providers within 2 years. So I talked a little bit about sort of thinking that this is really going to work this time. And I think that there's a confluence of factors around that. One, I think, is the mandate, right? I think very specific, clear legislation from the Connecticut State Legislature saying, nope, we are setting up an HIE and you must participate in the HIE if you are licensed in the state of Connecticut as a healthcare provider. I think that is a pretty big stick that's out there for Connie. That said, what I have found, and in some ways, the pandemic and COVID, I think helped highlight for us, and as you were saying, niche healthcare organizations. I think what that brought to light is, though we have a lot of Epic institutions, though we have most of our providers are on some electronic record or another, we're still pretty disconnected, and we're still pretty siloed, and we're not as interoperable as one would hope. And I mean, Connecticut is a state, like, it's this big, it's tiny, right? We're just not, we have 3.5 million people. We have some of the best healthcare institutions in the state, for sure. But even in a state like Connecticut, we found that we had these pockets of just information gaps where organizations were not as connected as they could be. And I think as I've gone out now and talked to healthcare systems and providers, I'm not getting this pushback of like, I don't need to be connected. I'm on an EMR. I still have a fax machine. I don't know why we need this. I think the pandemic has helped really highlight for folks, oh yeah, we've got some work to do. And there is probably a need for us to find a common convener, if you will, across the state. I think the other nice thing for the way that we've been set up is we are an independent, neutral and trusted entity. So we are not a state agency. Mm-hmm. We're not owned by any one for-profit entity in the state. I'm not owned by a health system. I'm not owned by, a provider group. I really am an independent body that is there to be neutral and trusted among all of these. So we have an independent board of directors that are made up of individuals from most of our stakeholders. So health systems, FQHCs, consumer representatives, physicians, payers. So sort of a broad swath of the healthcare ecosystem are on our board and have a say in sort of our decision making and how we get things done, which I think really goes a long way to helping folks feel like, well, I don't know if I want to give my data to Connie because, is someone else going to use it against me? That's not how we're set up. That's not what we're going to do. And I think that goes a long way to helping folks feel comfortable with Connie and moving forward. Your question off a little bit there, but
yeah, no, that's great. I think the background's so important. And for me, I hear a lot of parallels in what you're describing in the way that your organization is set up as a neutral, trusted entity. Yeah. That sounds a lot like Direct Trust, just at a different level. And there have been so many conversations recently within Chic and now Civitas. We're thinking about how trust is really local. And so there is that need to have those regional relationships and that regional convener. So it's wonderful to hear that Connecticut finally has an institution to step into that role and that you all are doing well, especially for being relatively young. I mean, starting in 2021 and the midst of the pandemic, that's a lot. And I heard you say with your board and some of your stakeholders, you have patients who are involved, which I love to hear that. I'm also interested too, and maybe learning a little bit more about the provider involvement and how Connie, maybe just in general, how does Connie benefit providers in the state of Connecticut?
Yeah, so we fortunately have a number of providers that participate both on our board, as well as we've had the state of Connecticut has a Health IT Advisory Council, which we shorten it to HITECH. HITECH has a number of providers on that board who've given a ton of feedback into the development of Connie, even before we sort of knew what Connie was going to be. Providers participated on that. We hope to, and we will be standing up in our next fiscal year, which for us starts October 1st, a clinical council that will really be made up of physician and clinician users of Connie to give us that even more insight and in-depth sort of feedback on where we take use cases, how we develop Connie further. We have been fortunate to have a number of partners in the state that are helping gather and share information with clinicians that then we bring back into Connie. So earlier this year, we put on a webinar sort of introducing Connie to the state, and we had two primary care physicians, Dr. Joe Caranta and Dr. Alan Davis, give really poignant, meaningful examples of the places where they saw the pain from not having an HIE. So for example, Dr. Davis talked about his Monday morning patient. It's Monday morning, you've got this patient who's new to your practice. They were in the hospital over the weekend and you're scrambling, trying to figure out who this patient is, what their past medical history is, what meds are they on, what meds did they get at the hospital, what meds do they have at home, sort of what's their family dynamics and their family history, and sort of that being sort of adrift a little bit. And of course, doctors and clinicians are very good at sort of trying to make the best, asking the right questions and getting to the right answer in those kinds of situations where there's a lot unknown. But Dr. Davis, I think, made a really cogent case for being able to have access to data in Connie that would say to him, hey, Jenn Searls is here, but she's previously been at Yale, or she's previously been with East Granby Family Practice, and I can look at her medical history and I am now illuminated a little bit more, and I know what direction to take questions. And perhaps I've gotten an encounter alert from the hospital where she was this weekend. Perhaps I've gotten her discharge summary. And so now I can see, okay, now I have an understanding of why she was in, what she was discharged with, what meds she has now that she's home, and what my next steps should be. So I think he gave some examples like that. We've had a lot of physicians tell us, especially those who are in clinically integrated networks, that ability to have a broader view of a patient's information really helps them with managing total cost of care. So again, that idea that if I can go into Connie and see that you've already had a particular radiology exam, or you've already had a particular lab test, I don't need to repeat that lab test, right? I can look at that information, I can request it, see it, have a conversation with you, the patient, and now we can tackle your treatment, and I don't have to redo a test, and I don't have to send you and inconvenience you. So it's probably a benefit both to providers as well as to patients, right? Where I'm not getting inconvenienced to go get another test because you can't get access to the information that I had in my last one. So I think we hear more and more, or I'm hearing more and more these use cases where providers are coming with, hey, can Connie, and hey, is this going to be a possibility? So I think there's more use cases coming every day as we get connected with even more stakeholders.
Sure. And, as you were describing that, I'm hearing components of the quadruple aim, right? So
Yeah.
decreasing cost of care by not repeating tests, improved patient experience, because not only does their provider know some of their history, but, not having to repeat a test, decrease provider burden. So that's wonderful. And I think you'll see, as we've seen too, the more that people share their stories and the more that gets out there, the more that other organizations say, I want in, or I want to try that. So I'm really excited for you all to see, as you bring more and more organizations on, what that looks like, and just what the experience is, not only for your providers, but also for the residents of the state of Connecticut. So you also talked about new use cases. And one thing I'm interested in hearing your perspective on, there's been a lot of conversation recently about HIEs being a public health data utility. And where do you think that Connie fits into that concept? And maybe if you want to talk a little bit more about that concept too, I would appreciate that.
Yeah. I mean, I think it's a really exciting area for HIEs to dive into. And I think we've seen, again, COVID sort of illuminating some of this here and in other states. So we are fortunate to be able to partner with a technology vendor where we have affiliate HIEs, and so we're able to leverage their experience in other states. And so an example that I think is really relevant and really cogent is when you look at things like just recently COVID testing and being able to, and I'll use this word, it's sort of a bit gimmicky, but sort of hydrating COVID testing information with race and ethnicity data that you might have in the HIE, right? And or zip code data and census tract data, so that you can really start to make targeted inroads to say, we're not actually getting a good handle on COVID in this one area, and why not? What do we need to do there? And then when you take that another step and you look at vaccine information, and then being able to develop tools to allow providers to understand which of their patients at a population health level, right? A lot of providers do get immunization information right into their electronic medical records. So when they're seeing one patient in front of them, they can see whether or not they've got immunizations. But to be able to look on a population health view of your patient panel and seeing where you need to make outreach, you need to make inroads, because maybe there's this bulk of your patients with chronic conditions that you really need to target for outreach, or maybe you've got a segment of your population that's gotten one shot but not two shots, right? And so really being able to drive that kind of information and sort of hydrating clinical information with additional information we might have about patients allows us to really utilize HIEs as that true public health good. And so we saw a lot of that with our affiliate HIEs. We were, since we weren't even operational until May, we were sort of at the tail end of that work here in the state of Connecticut. And to be clear, Connecticut did a fabulous job has been doing a fabulous job. But certainly we saw with our affiliate HIEs this ability to really leverage the data that's within HIE for public good and for public utility. We know things like, and some other examples, lead registries, and really being able to facilitate that. Or we know that we have some organizations that are able to do things like have birth score alerts, right? So that as newborns are born and being able to be alerted for those newborns with low scores, so that you can put the appropriate interventions and resources and alert care teams to take care of them. So all of those kinds of areas of focus, I think can be facilitated. And I think HIEs are probably in the best space to be able to facilitate that for the public good. So I'm excited and interested to sort of get Connie up and running so that I can start tackling some more of those use cases that I think really speak to me individually as trying to do good for the citizens of my state.
Sure. And one thing that stuck out to me as you're talking about the public health data utility, and I liked your word hydrating and kind of pulling that data together and looking at trends. A couple of weeks ago, President Biden was calling on primary care providers to do outreach to their patient population and figure out, those who hadn't been vaccinated and to try and get them vaccinated. So how do you do that? If you have your patients everywhere, how do you get those records in? So I think this is so relevant, looking at addressing a public health need and the spot that HIEs like Connie can certainly step into. So kudos to you all for doing that work. And it's also so impressive to me that the community of HIEs and just interoperability and health IT in general, that it's so collaborative and we learn from each other and we build off of each other. So I think to that end too, I'm also curious, are there any obstacles that you've encountered, or maybe even obstacles that you were able to avoid just based on learning from your peer HIEs, or anything that you would want the health IT industry to address because you encountered it as an obstacle recently as you were standing up, Connie?
Yeah, that's such a good question. I think some of the obstacles that we may have, I think, are sort of universal obstacles across a lot of HIEs, or at least I've heard that. I do agree with you in your estimation of the HIE community as being highly collaborative. It's a strange mix of, oftentimes you can be competitively collaborative. I'm going to coin that phrase. I don't know if it makes sense, but you know, we're sort of sharing the same space, and yet it is a very collaborative. Generally, has been to me a very collaborative, open. You know, I can call up almost any other executive director or CEO of an HIE cold and just say, I'm running the HIE in the state of Connecticut and I have a question. And inevitably, and so far, you know, 10 for 10, folks will happily take my call and happily answer my questions, even if they sound sort of really naive and misguided as I'm sort of learning this interoperability world. So yes, 100%. I think we're all in sort of the same sort of struggle these days, which is for all of us, high-tech funding is coming to an end at the end of September. And long-term sustainability sometimes hasn't been at the forefront of every HIE's plan. That's probably not a fair representation, but it certainly is a concern for many HIEs as we look at the end of that high-tech funding and say, okay, well, what does that mean for us going forward? And how do we maintain this, and how do we develop value for our community in such a way that folks will pay for what we've got here? So I think, you know, for me and for my team, I came along in November, and it was sort of like, oh, and by the way, all of your funding goes away in less than a year. So good luck and figure out a sustainability plan, right? But I think we're all sort of faced with those challenges. I think, you know, I think it's always a challenge in this world. You're always up against glossy, shiny, for-profit, venture capital-based organizations that can afford to hire the best programmers and have the best user interfaces that are sort of slick and do, you know, amazing things and glitter brightly. And I think that's always a challenge for us in this world, right? Where in some ways just we got to sort of slog ahead and get data moving where it needs to go. And we need to get data moving where it needs to go for everybody, not just the folks who can pay for it, right? And I think I have sort of been converted, if you will, or sort of my eyes have been opened a little bit to some of those challenges where this is sometimes not really glamorous work, but it is so important, and it's so critical for our healthcare providers and our patients to have this work happening. But it's hard to get folks to wanna, you know, there aren't angel investors out there with $1 gajillion ready to invest in a not-for-profit. I wish that there were, and if any are, you know, looking for some place to invest, come on down. Yeah. There's Connie. But I think that those are some of the same challenges that all of my colleagues and other HIEs are facing in various ways across the other states.
Sure. And, you know, I think what just resonated with me is health IT isn't glamorous, but it's worthwhile, especially in the nonprofit space. So I feel that in my soul. I love that. I love that you shared that and said that because I think it's so true. And along with that, I'm also curious, do you have any advice for others who maybe aren't quite in your footsteps, but maybe are new to interoperability or looking at making progress in interoperability? Any words of wisdom for them?
Probably just the saying that I have behind me, which you know, a fellow executive director of an HIE sort of points out that had she not been a sort of long distance runner, that she might have given up on HIE a long time ago. You sort of have to just keep slogging through it. And I am so far from being, you know, I'm sort of flattered at being named an interoperability hero, and yet sort of feel like, oh my gosh, you guys picked there must be another Jenn Searls and you picked the wrong one, but okay. Only because I feel like I still have so much to learn and there's still so much to go. But you really do just have to keep sort of slogging in and day out and sort of just keep showing up and just keep getting data exchanged. It is so helpful when you hear, you know, patient stories or provider stories or clinician stories where you think, oh, that's why I do what I do. Because that, you know, a patient who doesn't have that horror story of showing up at the ED and not knowing what mom's meds are, that's why we do what we do, right? And there is for me that you talked about sort of working for a not-for-profit and sort of mission driven. And there is for me that sense of, I really like this work because I get to facilitate those kinds of stories, and those kinds of stories are really meaningful to me. And I want to keep doing that across the state and just keep slogging through that for us.
Mm-hmm. And I'll give you kind of a peek behind the scenes a little bit too. When the interoperability hero concept came to be, it started as everyday interoperability hero, because I think there's so many of us who feel like what you just expressed. You kind of see the same figureheads over and over again, but really so many people are making the progress. It takes all of us to move interoperability forward. And so obviously from a communications perspective, everyday interoperability hero is quite a mouthful. So that didn't end up being the initiative's name, but I think this is a great point to highlight that it's the work that you're doing with your colleagues, not just in Connie and not just in the state of Connecticut, but the many HIEs who also have offered you advice or given you their words of wisdom. And so many people, I talk about frequently, I'm a big believer in collective wisdom. And I think that's what interoperability needs. And so you certainly have highlighted that and also kind of shown that you're on this path to success. And then more in the state of Connecticut, more patients are going to benefit from this more interoperable state. So certainly that is hero-worthy work to us at Direct Trust. And Jenn, I am curious if you have any final thoughts or anything else you want to share.
I don't know if I have any final thoughts. I mean, as I think I keep wanting to highlight, there is a whole team behind me. It is a small team, but it is a mighty team. And I benefit and I sort of stand on the shoulders of others who have been down this path, and as we've talked about, who have been so willing and open to be able to share their experiences with us, to help guide us where we need to go, to sort of set us on a path that has us sort of careening forward at a really great pace and making a ton of progress. So I sort of am happy to be the stand-in for all of those people, but there is a team behind us, and there are partners that we have at the state and with our technology partner that are really making it all possible, which is, I think, sort of true interoperability. So we're really, even demonstrating that in how we are running with this project. So I guess that's all I have to say.
Yeah, I love that. I love ending on that note. So Jenn, congratulations again to you and your team at Connie. And thank you so much for being with us and sharing your perspective today.
Thank you. It's been a pleasure.